Dr. Richard Krasuski from Duke University. Today we're going to talk about the data supporting the two strategies of medical therapy in patients with pulmonary arterial hypertension. The first is aggressive monitoring and escalation, and the second is a rapid escalation. So let's start with the data that is supporting these treatment strategies. First of all is the SERAPHIN trial. SERAPHIN was a study looking at macitentan versus placebo. It's important to note that in 2/3 of the patients that were enrolled into the SERAPHIN trial, they were already on a drug, in this case sildenafil. And so we were then able to look at the patients and compare them to look at clinical effect of macitentan in patients who were already on sildenafil and compare it to those patients who were not on therapy or treatment naive at the time. And so we have very good data suggesting that adding macitentan onto patients already getting sildenafil made a significant improvement. The other trial is the AMBITION trial. The AMBITION trial had a 2/3 randomization to combination therapy of ambrisentan and tadalafil versus the use of either ambrisentan or tadalafil. So in this particular trial, again, there was evidence that the use of combination up front led to a statistically significant reduction in clinical events. Now, the other set of trials we have are looking at riociguat in combination. So the PATENT study enrolled 45% of patients who were already on bosentan in the study and looked at basically adding therapy on to them. So this was again looking at combination therapy of riociguat and bosentan versus being on a single agent alone. Again, showed a statistically significant benefit that appeared to be very similar to the benefit that was seen in just treatment-naive patients. And then the RESPITE trial looked at patients. They're recruiting approximately 60 patients, of which 30 have already been presented, looking at switching from PDE5 inhibitors in patients who do not tolerate that particular class of drugs well to riociguat, again showing a benefit in those patients. And in those patients, actually, the use of an endothelin receptor antagonist was approved. And so we have some data, again, on use of riociguat as add-on therapy from that study. On the next slide here, you can see the data looking at the addition of prostaglandins, either inhaled or oral, onto baseline therapy. So GRIFFIN was probably the largest trial in pulmonary hypertension to date. And in this study, it showed that adding selexipag to patients who are either on bosentan or sildenafil, and in some cases both those agents, appeared to show a statistically significant improvement, actually again rivaling the impact of using the drug in patients who are treatment naive. There's also the TRIUMPH study, which looked at inhaled treprostinil and showed that you could improve 6-minute walk distance and reduce BNP in patients who are on therapy with a single agent when the studies started. And finally, FREEDOM-C and FREEDOM-C2, which were each trials basically looking at walk improvement for background treated patients. Both these trials did not show a benefit, but the combined analysis did show a dose-dependent improvement in those patients who were on background therapy. So what makes these relevant goals? First of all, it's very obvious that we can improve quality of life for our patients. So using multiple drugs in combination and using them early appear to improve clinical outcomes for these patients. In SERAPHIN, macitentan showed an improvement in health-related quality of life by month 6 with significant placebo-corrected treatment effects observed for 7 of the 8 short form 36 domain scores. So when looking at these scoring systems, there was evidence that patients improved their quality of life in most of the domains. Macitentan treatment led to significantly lower risk for those with clinically relevant worsening in their health-related quality of life. So again, it complements the impact of macitentan delaying disease progression, so quality of life clearly is improved, in addition to reducing the risk of morbidity, mortality, and pulmonary arterial hypertension-related hospitalization and death. And then the association between improved health-related quality of life and improved long-term outcomes were clearly demonstrated in the SERAPHIN trial. So in summary, there are a couple of approaches actually to managing the patient with pulmonary arterial hypertension. Again, one of those is to monitor the patient aggressively and add on therapy as is necessary based on how the patient does. The second is an aggressive upfront use of combination agents. In each of these cases, there is demonstrations of health-related quality of life in addition to the improvement in long-term clinical outcomes. So either strategy is reasonable, but again, the latter strategy has a good growing evidence base for its use. And I thank you for your attention today.